Okay, and let's go ahead and get started. Welcome everyone to today's presentation. Just a reminder, this session is being interpreted into Spanish. To listen to the presentation in Spanish, at the very bottom of your Zoom toolbar, there is a globe-shaped icon. Click on the icon, select Spanish from the menu that appears. Likewise, if you want to view the uh, Spanish language uh, slides. Oh my goodness, excuse me. At the top of your screen, there are two tabs, one labeled English MCN, the other one is labeled Español MCN. You can simply toggle back and forth between each tab, so to the slides that you would prefer to view. Let's go ahead and go to the next slide, Lois. Thank you. And again, welcome everyone to today's session using the Project ECHO model to provide diabetes education and resources. My name is Marta Alvarado. I am the manager of online education for MCN. And this session is just going to be an informative session about the 6-part diabetes education series that Lois and I put together, provide every year for our MCN constituents. And this is, again, it's just going to be an informative session, and we'll just go ahead and go on to the next. And with that, sorry, with that, I'm going to go ahead and turn it over to you, Lois. Thank you so much, everyone, for being here.
Thank you very much, Martha. My name is Lois Wessel. I'm a family nurse practitioner. I do myself work in a health center in Silver Spring, Maryland, and I'm also an associate professor of nursing and medicine at Georgetown University. And I've had the honor of working with MCN for a long time. I think we always forget, but like our 7th or 8th year doing this. And I do see that Deborah raised a hand, so I just want to make sure that there's nothing technical, that you're seeing the slides. Was that your question, Deborah?
Deborah, you can ask your question in the chat as audio is not enabled for participants.
So I'm going to go ahead and Martha will problem solve if it's a technical issue. But today we're going to talk about the value of the community health worker as part of the healthcare team when we're talking about prevention and treatment of a chronic disease, which is that of diabetes. And I should point out here that we are, for the most part, talking about what we call type 2 diabetes and not insulin dependent diabetes, although in the course itself we do touch on that, just to make sure our community health workers have the knowledge to understand the difference. We're going to talk about Project ECHO, and for those of you who don't know what it is, I will explain what it is as a model for training community health workers and describe the evidence that we used and why we use evidence-based training and linguistically appropriate patient education tools in our training that then we pass on to the participants so they can use them in their community. And then we'll talk about the importance of community health worker training in the target language, the language of origin that our community health workers are using in their workplace. And I should say that in addition to doing this for so many years, some of the knowledge that I've gained was through the support of MCN in doing my doctoral research for my nursing doctoral degree on MCN and the delivery of Project ECHO in this community. So I want to start out by saying that why are we focusing on community health workers? Really, really interesting to me to note that employment of community health workers is projected to grow 14%, which is in the next 10 years or so. And that is much faster than the average of all occupations. I'm actually delighted that nurse practitioners are one of the fastest growing professions, as are community health workers. And we certainly have seen some deficits in our healthcare delivery system. And community health workers are ways that we can address some of the shortcomings of our health system, because they are community liaisons. They know what's available in the community. They're aware of how to do case management and care coordination and provide social support to advocate for their patients. More than anyone, they know resources in the community, everything from what are the bus lines to where you can buy certain products at a reduced price to where the farmers markets are. They're very good at educating in the target language and doing patient navigation. And so I really see community health workers as part of a team where we really want to put the patient in the center, and we want to make sure that we, as part of the healthcare delivery system, are attending to all the needs of the patients. And I know as a frontline nurse practitioner, I could spend 2 hours with each patient and figure out the bus line to help them get to where they need to get their blood drawn for their to assess their diabetes, but I don't have time to do that. And if I can turn that over to somebody else who can talk to them about all the resources in the community, it frees myself up to do more direct patient care. And so we talked about
Lois, can I interrupt you for just a second?
yes,
Just if you could just slow down a little bit for our interpreters.
yes. Sorry
Thank
about that.
you. No worries. Thank you so much.
Okay. Having been an interpreter myself, I appreciate that. Okay. So we've talked about why community health workers, and I want to talk about why diabetes. It's estimated that there are close to 40 million people in the United States that have diabetes. So I've heard everything from 1 in 10 to 1 in 12, even in some communities, 1 in 25. The last statistics we have that close to 30 million people have been diagnosed, and that there's another 8 or 9 million who are undiagnosed. And that's a concern to me because obviously with diabetes, we want to make sure that people are getting the care and attention they need to prevent the complications from diabetes. And then within the Spanish-speaking population in the United States, it's a little over 11% of people who have a diagnosis of diabetes. And if we take that large group of people and then we combine it with the people who are pre-diabetic, and in fact, sometimes I think everybody is pre-diabetic until proven otherwise, we know that there is close to 40% of the population, adult population, who's pre-diabetic. I know in my age range, it's sort of the joke now, you know, the women all go on medication for osteoporosis, and the men, many of them, and some of the women are starting to go on or change diets or start to think about pre-diabetes. We are living longer in the United States, and our bodies get tired of working so hard, which is one of the reasons why people have insulin resistance. And so of people who are older than 65, it's a huge number. Almost half of the people in the United States have prediabetes. And sadly, in the Spanish-speaking population, we are diagnosing type 2 diabetes in a very young population, even in the pediatric population. This slide talks about youth and young Latinos. And I know in my health center, we've seen it for children as young as 8 or 9. And there are many factors, diet and lack of exercise, that come to play there. So we've talked about community health workers. We've talked about this serious problem with diabetes in our country. And I would like to spend a few minutes talking about Project ECHO. And Project ECHO stands for Extension for Community Healthcare Outcomes. So this project, or this modality, was developed by a group of healthcare providers in New Mexico, started by Sanjeev Arora, who by training is a doctor who works with hepatitis B patients. And what he found was that many patients in rural New Mexico were diagnosed with hepatitis B, referred by health centers to providers in Albuquerque and in Santa Fe in the cities, and then not showing up for the appointments because there were transportation barriers, there was time off from work barriers, there was, I don't want to go to a city where I don't know how to get around. And so him and his team developed a program where they would be the experts, and they would empower people in the health centers and private practices in rural areas to become the hepatitis B clinician and to treat hepatitis B in the primary care setting. And they did that by sharing the medical knowledge from the specialists with the primary care providers, who then in turn shared their patient dilemmas and their patient stories and their conundrums in managing a disease that many of them had not been taught how to manage when they were in their medical training, whether it was physicians or nurse practitioners or PAs. And lo and behold, they found that people who were treated by non-specialists with the support of specialists had the same outcomes with hepatitis B. In other words, the same viral loads, the decreasing viral loads, as people who were treated by specialists in the city. So that was the start of this great Project ECHO, which now I will explain in a minute, is all over, not only all over the country, but all over the world. And the modality that they used, and remember that this was 15 years ago or so, so it was way before COVID and way before Zoom was a household word, that doing this teleconferencing as a way to communicate with people in areas outside of the city where you were was a great way to connect specialists from all over the state with providers. Some of their core tenets were to use evidence-based information, case-based learning. In other words, the clinicians from the rural areas would bring a case and it would be talked about in the group and in open dialogue, and then to track outcomes. As I mentioned, tracking the patient outcomes with the patients who were served by the specialists. Being served by the primary care providers with support from the specialists. So that was the launch of this great Project ECHO. And I'm going to come back to those four ideas: case-based learning, patient outcomes, evidence-based care, and learning via online modality throughout this presentation. And so the model that was developed by Project ECHO was to have a team of specialists who could empower participants in their place of work, who then would know the community resources and perhaps share resources with each other. And so just as important as the specialists are the people in that sort of blue circle, the ECHO participants, as well as people in the community who are sharing community resources and how to reduce barriers to care that may exist, and share those with each other. So there's really a lot of lines going back and forth between the specialist, in my experience sometimes, and anybody who's on the call is a specialist, I'm glad you're there, but sometimes they're not quite as in contact with the community as the primary care people and community health workers who know more about the community resources. So this is the most up-to-date map of where there are ECHOs all across the world. So we see from Russia to Canada to Africa to Australia. There's only one dot in the United States because that is a dark color, and I know that may be a little hard to see, but that dark color indicates that there's over 100 active ECHO programs throughout the country. So now we're going to take a slight pause and ask a poll question here, and we're going to ask it verbally and let you put your answers in the chat. So Martha, I'm going to let you go ahead and ask that question.
Thank you, Lois. And we just wanted to just quickly check in with you guys and ask, does your agency or clinic use CHWs? And it's just a yes or no question. You stick it in the chat. Appreciate it.
Great. So we're getting a lot of yeses.
And while I have you guys here, I failed to point out earlier that we are going to have a former participant from our ECHO series from this year just talk a little bit about her experience towards the end of the presentation. So thank you.
So now we're going to move into what MCN has done with ECHO and community health workers. And it's kind of it's almost a perfect marriage here, where you have a very dynamic training session or training modality, which relies on the strengths of people in the community to share those strengths with each other, as well as specialists who are providing information to community health workers that they can use in their practice setting. And I think one of the very unique things about MCN's work is that we are able to connect with community health workers who all work in similar but different areas Some are urban, some are rural, some are in health centers, some are in faith-based organizations, some are in county health departments, some are in academic medical settings, but it's all people who work directly with patients who need much more than what the doctors and the nurse practitioners and the PAs can provide with respect to a lab slip or a medication, but they need a tremendous amount of education to manage chronic diseases and to prevent the sequelae from uncontrolled diabetes. And so, as we've mentioned, for the last close to a decade, MCN has been carrying out these Echo Diabetes series where we focus specifically on what is diabetes, how can it be prevented, in other words, that big group of pre-diabetics, and how can it be managed to prevent the outcomes in populations that tend to often have worse outcomes and end up on dialysis or with an amputation. And we know that those things are terrible for the individual and terrible for the community and terrible for the healthcare system. I think one of the strengths of the work is this knowledge that is shared back and forth. And I have to be honest that I learned just as much from the community health workers as hopefully they learned from me, because they've had patient experiences that they share to, and remember we talked about these learning loops or case-based learning, where this information is passed back and forth. And for reasons I don't understand, this slide, oh, it popped in, okay, thanks. Shows you a little bit of the format we like to use. It varies every year depending on the availability of some of our consultants and their schedules. But we spend the first session talking about what is Project Echo and the expectations that they are active participants. They're not there to just swallow information, but they're there to reflect, to respond, to share, to engage, especially to share stories that they've heard or experiences they've had. And I think that's been one of our take-home points with a more formally trained population. We talk about case-based learning, and one of the things I spend a lot of time doing with my medical and nurse practitioner students is teaching them how to present a case. And it's an expectation that you come in and say, a 46-year-old man with uncontrolled diabetes is in the clinic and blah, 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 blah. And that very methodical way of presenting a patient is not really in the framework of the community health worker. So we explain to them that however they want to talk about their patients, understanding confidentiality issues is what we want to hear. And then we talk about the different kinds of treatments for diabetes. I would say that the treatments and the technologies in diabetes have changed tremendously in my career. And many people are more used to the continuous glucose monitors for people with type 1 diabetes, but we're seeing it used in type 2 diabetes. There's a lot of medicines that we throw their names around. And so we have Dr. Eva Galvez, who's on the board of MCN and is a family practice physician in rural Oregon, present on that. We spend a lot of time talking about nutrition and how nutrition is so important both in prevention and management of diabetes. And again, that involves reading labels, understanding what a carbohydrate is, talking about the cultural impact of encouraging your patients to use brown rice instead of white rice, talking about the fact that in the Latino diet, often there's a lot of carbohydrates, and how we can make sure that people are celebrating their cultural food norms, but also doing it in a healthy way. Then we talk, and I think in some ways this is one of the more impactful ones, about the relationship between any chronic disease and mental health. And people who are depressed are more likely not to be taking good care of themselves, and people get a chronic disease diagnosis like diabetes and its cousins, hypertension or hypercholesterolemia, often get depressed. And so we talk about that balance. And then we spend a class talking about all of the complications of diabetes, which is pretty interesting because you learn how diabetes is a disease of too much sugar in your blood, and how your blood goes everywhere in your body, and so how different parts of the body are affected, from oral health to your feet. And then lastly, we pull it together with Alma Galvan, who is a staff member at MCM, who really kind of reinforces the value and the role of the CHW in the work that we do. So as I mentioned earlier, one of the goals of, and those four tenets of Project ECHO, is to have patient outcomes. We're really good at measuring the knowledge gained by the CHWs themselves. It's a whole other level, and in fact, Project ECHO's main home at University of New Mexico, they have been able to do many more, because of their resources, patient outcome studies. We know that there are many factors that influence people's outcomes with diabetes, and many of our community health workers don't have access to the electronic health record to see what's going on. But our long-term goal is to keep diabetes well controlled, and that means with a hemoglobin A1C, which is the lab test we do to assess control of diabetes, to keep that to 9 or lower. But in order to reach that, our short-term goals are to provide knowledge at a level and in a way that people understand, share practices, and that's practices that we know about and practices that other people bring to the table in diabetes self-management, create, and again, think back to that wheel, create connections among the community health workers about available resources in their communities. And often somebody say, I have a really good handout on that, and they'll send it to Martha, and Martha sends it out to everybody else. And then obviously all of that is focused on improving patients' abilities to take care of themselves and to take care of their diabetes, which hopefully will lead to this long-term goal of reducing hemoglobin A1C numbers. So this lovely map of the United States and Puerto Rico shows where people are from in the different training sessions. And so if you see a bunch of different colors, that's because we've had repeat people from there in different years. So for example, the yellow is the year 2020, and the dark blue is the year 2019. So we're really delighted to have a presence in most parts of the United States. And in fact, when we select from the large group of people who apply to be part of this, we really look for a geographical distribution, both for each cohort to be geographically distributed, as well as where they've had people from, where we've had people from in the past. So my guess is if somebody from Montana or Wyoming applies, we would be happy to have them, because we haven't quite hit those places yet. But as you can see, we've pretty much been in most parts of the country. And then, as I mentioned, we want to make sure that the information that we are giving is based on the best knowledge that we have. And to that extent, we rely on the American Diabetes Association guidelines on care of patients with diabetes and prediabetes. And in fact, looking at our curriculum and how we adhered to those guidelines was a significant part of the research I did for my doctoral training, and we found that yes, we are in the sort of all 98% or 97% on most of the um, information we give in the class is something that can be found in the American Diabetes Association um, guidelines. And then as we teach about all of these areas that I talked about each class, and those are listed on the left, we provide patient education materials in the target language as part of our training for CHWs to use in their place sitting. So this one is, the first question is, what what is this medicine even for? How will it help me? Um, what should I do if I forget to take one of the doses? And so this is a patient education document that the community health worker and the patient can fill out together to make the care personalized to that specific patient. When we talk about other content that I mentioned, again, these are the types of materials that we use so that these materials can be reused by the community health workers in their practice setting. So the one on the left is actually one of my most favorite diabetic handouts, and that is something that is based on concepts that, regardless of people's education and literacy level, people understand the stoplight, and I've seen similar things for asthma education, but we know if you're in the red zone for your blood sugar, stop. Something's not right. You need to make a change. The yellow or orange zone, yeah, you probably shouldn't go through the yellow light. You might be haunted by it, but maybe not the end of the world. And then the green, you're doing okay. And again, it has a smiley face to a sad face. And one of the complicated things with for anybody with diabetes, regardless of language of origin or literacy level, is that there's a lot of numbers involved in diabetes, and we talk a lot about health literacy, maybe not enough about numeracy. And in diabetes, we look at the hemoglobin A1C, which is a blood test that talks about diabetes control over 3 months. And then we talk about a number that you get with your diabetes, when you test your blood sugar with a finger stick. And those are two separate numbers that sort of have a relationship. So this will kind of explain if you're testing your blood sugar at home and you're getting in the 200s all the time, your hemoglobin A1C might be around 10 or higher, which is higher than that target number of 9 that we had before. Similarly, with the patient education example on the right, this is something that talks about everything from how diabetes can cause neuropathies to dental and oral health problems to kidney damage to eye damage to sexual dysfunction to problems with the feet and the peripheral vascular system, so that the community health workers have the knowledge to explain how diabetes affects every part of the body to the clients they work with. And coupled with that information is a specific comic book that MCN put together specifically about diabetes. And I think we live in a world right now where the graphic novel has really taken off. For many reasons, people don't read as much as they used to, even communities where people are avid readers. They like to have things short and sweet. And so MCN has put together a comic book that talks about diabetes. And one of the things that we do as we share this with the participants is tell them that they could photocopy certain pages as they slowly do diabetes education. So on the left, you might have carbohydrate reduction and how to do a healthy plate, whereas on the right, that page talks a little bit more about reading a nutrition label. And this can be overwhelming the diagnosis of a chronic disease is overwhelming to anybody, and handing out the whole comic book can also be overwhelming. And so we talk to the community health workers about handing it out, um, different pages of it slowly, as they do patient education, and encouraging their clients to put these pictures up in the refrigerator and share them with their family, especially because of pre-diabetes. So if your patient who's diabetic is committed to getting off sugary soft drinks, probably the rest of the family who might be on them too should consider that. And so we talk about ways that the community health workers can make this very family based, and individuals can share the information with families. And one thing that is really exciting about this is that we have recreated the comic book with different sample plates, like plates of food, and language, for different communities. So there's one in Haitian Creole, and we have one specifically focused more on Caribbean Spanish. As you saw on the map, many of our participants come from Puerto Rico. And then we have another Spanish, which is a little bit more based on the Western United States, Spanish, Texas, Arizona, California, New Mexico, because we know that different Spanish words for fruits and vegetables can have different meanings. And so those books have been developed to have that information available in different types of languages. And then when Malawi Garcia, who's a psychologist, comes and talks about mental health and depression, we really get into a deeper understanding of something I touched on before, and how if you're suffering from depression and what people in Spanish may call depression, which they might call it, something like a case of the blues, or feeling down in the dumps, or many different Spanish terms for depression, and not calling it depression, how that affects your ability to exercise and to eat right, and even to go to your medical appointments. And so we talk about all of the factors that can lead to good control or bad control of your diabetes, and what role the family plays, or the community plays, or the institution plays, including people's health knowledge, their social support, their socioeconomic factors, and how all of those things come to play in diabetes control. And I just wanted to emphasize here that what most of us who go through provider training programs are taught to do is, this is what their A1C is, this is what your medicine is. Oh, they also have high blood pressure, you should add this medicine. Oh, their diabetes isn't well controlled, we might need to add this medicine. And it's great scientific knowledge about treating diabetes, but it doesn't really look at the whole person and the other influences. And so that's really a strength that the community health workers bring, where they have experience in the community. Many of them talk in their application about they themselves have been diagnosed with type 2 diabetes, or maybe a family member has. And so they bring a lot of personal experience and knowledge to helping patients get diabetes under control. And again, I always think back to the brown rice situation, where I heard a community health worker once say, they told me that brown rice is better and it won't make your blood sugar go as high, and it's healthier, it has more nutrients, but I didn't really like it at first. I thought it tasted like there was dirt in my rice. But I kept with it, and actually now I like it better than white rice. I just had to get used to it. And that carries a lot of weight coming from somebody from the community, much more than it does, I think, for me as a provider when I tell that to my patients. That's just another example of the entree that our community health workers have into the patients. And as I touched on before, one of the 4 tenets of Project ECHO are these case presentations. And one thing that made me feel a little bit better is that when Martha and I attended the Project Echo conference a year and a half ago in Albuquerque, we found that that was a challenge for many of the other Project Echo groups. Some people come and they want to absorb all the information that the specialists are giving. And for us, one of the strengths is that we present that information in Spanish, so they're hearing the words and they're hearing the terms in the language that they're going to be teaching in. So we've really kind of rephrased that we don't expect people to do a case presentation, but we expect people to share their experiences, including their highs and their lows. And we have had everything from, like one of the things that came up last session, I think, was a community health worker said, I've done a lot of education, yet the patient still ended up with a leg amputation, and I feel really bad that I couldn't stop this. And we explained how we do what we do, and there's a lot of factors that play into this, and that being there to support each other and our highs and our lows as part of the healthcare team is really important, and we're not always going to be successful. And again, the number of sort of going around the circle, the number of times that participants have communicated with each other about solutions has been really valuable. And so we stress sharing actual experiences that happen in the clinical setting, but we don't always expect it to be a case presentation in the formal setting. This to me is very interesting, and I spent some time actually yesterday talking with a statistician I work with at Georgetown about this concept. But originally, we do a pre-test, what knowledge do you have? And we do a post-test, what do you have now? And that's the way a lot of us in a lot of webinars and education sessions participate in. And we found that many people overestimated their knowledge going into something, because we all like to think we know a lot. And we found that if we give them the two post tests, one that says, before this course, this is what I knew, and then the second one, after this course, this is what I know, it gives them a chance to reflect in a more immediate setting on what they learned in the course. And all of these questions are on a Likert scale. I think there are 13 different questions that we're looking at their ability to advocate for patients, or ability to discuss diet, or confidence in talking about blood glucose monitoring, or understanding how exercise and activity relates to diabetes management. And sometimes when we see that there's a certain area that their knowledge didn't increase so much, I see that as a guide to where we need to put more emphasis the following year to make sure that our teaching is helping them get that knowledge. And so Martha was kind enough to put together a bunch of different graphs that where we look, the first line is sort of the pre-knowledge, and the second line is the post knowledge, and the red line in the middle is the median, and we've been able to see how what the percentage change was for each of those things over the whole course of the training, and there's 18 questions. And so without a doubt, we've seen every year that people's knowledge has significantly increased by 30%, 23%, close to 50%, close to 30%. And we don't have for you broken down here today what all those are. with each question, but we do have some of that data, so we can look at, again, what their areas of great learning are and what their areas where we could do a little bit better. And so as you see, it's mostly been that they've had about a 30% increase in knowledge, 35% based on these 8 years. And this is self-reported knowledge, and which is, you know, appropriate for this kind of training. I would say that as pleased as I am with the training we've done, there have been some things that we continue to learn from. It is always the expectation that people have their cameras on and we can create community. We also know that for some people it's lunchtime, or they're in their cars, or they're multitasking, or they're in a resource poor community where they don't have cameras, or their internet is unstable. And so turning their cameras off makes it, you know, gives them a little more bandwidth. We do ask people to come to all 6 sessions. We make them sign something said they're going to come to all 6 sessions, yet many times they don't. So their attendance can be irregular. There's a variability among community health workers in different states. Some states require community health workers to get ongoing continuing education. We're not offering that right now, but we know that for many community health workers that is a requirement in their states. However, a big bonus is that we really do build community, and there are people feel less isolated. And I think about this a lot. I love the staff I work with, the physicians, the nurses, the community health workers. But sometimes when the nurse practitioners hang out, I like feeling less isolated, and we have some of the same challenges and experiences. And I think it's really good to have a multi-professional team. At the same time, people need spaces for just their profession. And we've had participants who say, you know, I hear that term diabetic retinopathy all the time, and it wasn't until I came here that I know what that meant, and I was embarrassed to ask it. I know that they had to go get their eyes tested to make sure they didn't have it, but but you helped me understand exactly what that means. And so that's one of the ways that we've been able to help reduce isolation. I do want to make sure we get time for Dene. So Martha, how are we doing with time here?
We're doing good with time, Lois. No
Okay.
worries there.
Okay. So these are just a couple of little quotes that we've had from our post-session evaluation. I'll read a few of them. I've learned there are resources available on when we should refer a patient to a mental health care provider. Again, really important to understand the connection between mental health and chronic disease, and to understand that from the perspective of potential mental health stigma in the community. Somebody else said the ECHO series is a wonderful opportunity to learn. I learned a lot of information that I will implement in my program. The learning materials and techniques were well used. The host kept us on the objectives of the topic, and the speakers contributed their knowledge and experience. And I think, again, that they really like hearing from a nutritionist, a psychologist, a physician, a nurse practitioner, Alma from MCN, who has a lot of experience with CHWs. They like hearing from these different specialists. And remember, the middle of the hub is sort of the ECHO model are the specialists. And so they really enjoy hearing from the specialists. Thank you for the organizers for having the wisdom and understanding of our communities. And again, I think one of the biggest takeaways is that people want information in a language and at a level that they can understand. And I think I skipped the slide with Danae, so I'm going to go back to that in 1 second. And sorry, Danae, I didn't mean to do that. So what is really great is that we have the ability to take a very successful and proven model and adapt it to the needs of our community health worker population. Community health workers often need additional training on the chronic diseases they're working with. They may have had little official training on these diseases. We do want to be able to always figure out patient outcomes, and that would be a goal of ours, as in any health provider training program. Obviously, additional funding would help us improve our evaluation methods. We really hope to make an impact on the fact that so many people have complications from diabetes, and so many of them are from our Spanish-speaking population. And if nothing else, our demand is higher than our ability to do the training. And sadly, every year we do have to turn a few people away. So again, I apologize that I skipped this slide. That was not intentional, but I'd like to turn it over to Danae, who was one of the CHWs from Puerto Rico who participated in our class this.
And let me jump in really quickly. Danae is going to do her little presentation in Spanish. So for those of you listening in English, you might want to change your channel. This is Danae Perez. She joined from Camuy Health Services in Puerto Rico, and she's going to tell you a little bit about her experience as one of the participants for this year. Gracias, Danae, for being here.
Gracias a todos. Me indican si me pueden escuchar bien.
Sí, te escuchamos.
Gracias. Nuevamente agradezco.
So again, I want to say thank you to our peers, our colleagues here of MCN. As it was said, I'm Danae Perez. My position here is health educator, and part of my functions is to create, plan well-being programs and execute them, preventive health programs for communities of the municipality of Camuy. In Camuy Health Services, we are a corporation that is an NGO, and we're community-based, providing primary and preventive health. And nowadays we are acknowledged and recognized by the federal government, and we receive federal funding through a section called 330. Or Public Health Services Act. Thanks to this, we have many programs which have been of a lot of help. We used to have a health educator called Nidia Velasquez, who is a very important person in public health, especially in our profession of health trainers, because it is the foundation of this program, and as part of my community work is to share and look for ways to create or have access to content on health that would be hand in hand with the language, as well as with the literacy of people, literacy level. Something that happens in Puerto Rico is that, at least according to the most recent information and data from the health department, is that we have a lot of people living with diabetes who do not know about it. In the most recent research and statistics study in 2022, 1 of every 2 adults do not know they live with diabetes in Puerto Rico. And unfortunately, 1 of every 6 adults in Puerto Rico has diabetes. Puerto Rico, as it is a colony of the United States, has certain benefits and a culture that is shared with the U.S., and same ways access to food and lifestyle and food consumption that increase this incidence. So together with people more and more moving less. This happens because population is aging more and more, and so the motor abilities are lower. That's why programs such as the CHWs Health Services are so important to restore the patient. How? Well, providing the patient with the tools and with access to education strategies that will help him understand that you can live with health and good with your sugar levels controlled. This is, you can have diabetes but controlled. One of the programs of CHWs Health Services is called I Have My Diabetes Under Control. I Dominate It. And the main purpose is to educate a group of people so that their A1C or glycosylide are under 9. That's the indicator and the matrix of our institution. And as part of this, my task, my duty was to get in touch and receive education by a group of people that we know as MCN. And MCN has been a great help for this program that is I Can Dominate My Diabetes, because it has provided us with the material and information and education related to the development of this condition of diabetes, and visually presents with the comics. They use a lot of visuals, stories that can easily connect. And so our population, even when most of them has literacy, we can use a more, like a deeper knowledge, and we can identify that in the municipality of Camuy and probably in other places in Puerto Rico live with functional illiteracy. This functional literacy means that the person reads, at least they understand it briefly, but for them it's difficult to understand health, difficult concept. And there is where our promoters, our educators on health and other communities health workers, employees, and groups of people work jointly using MCN materials and strategies based on evidence, so that way our programs strengthen and our patients are educated. I love it. I discovered it in a referral of a peer of mine, and after that we realized that they are very, very well accepted, these comics and these materials. And what I enjoyed the most and learned in these eco classes was the ability to convey or transmit this information, which is in a plain language, in a simple language, direct to the point. I love the therapy piece, and a lot of these aids are turning in education for our suppliers, for our doctors, and little by little we're integrating this technology of glucose continuous monitoring and exploring other alternatives, but without leaving aside this medication that maybe can be more accessible. This is part of our values, accessibility. And this is how we commit the patient, so that in a creative and original way, but also in case there's no possibility of a treatment, they can have other alternatives that are traditional, and that way they can have some control on their diabetes. And this is something we feel very thankful about. We want to say thank you to MCN and the ECHO workshop, because the information itself, as Luis said very well, can be obtained in the national platforms or in the Department of Health of Puerto Rico. But the information is not the important part, but the way you convey the message, that's the key. And I think ECHO has done an excellent job in it. And most of all, the information material of the comics, we will be using, continue using it, and any other information, it's welcome. Here in Camuy Health Services, we will be speaking about some of them in an event that we will carry out on June 19th. In Camuy Health Services, we have something called Eco Healthy Summer, and we have special activities in which all the peers and patients who have received this information can basically look at it and visualize it. So using the eco materials and the evidence-based materials, this can become key for our patients to keep on this same pathway, taking care of their health. So I want to say thank you very much to MCN, your team, Marta, who's all the time sending us emails in a very efficient ways. And we are here at your service. And we can email each other, and that's the distance we have between us. Only an email.
Muchas gracias, Danae. Thank you very much, Danae. And we also have Barbara Estrada Reyes, who said that in the chat that she participated in this course, and she gives education about lifestyle changes, not only for adults, but also for young people who have high cholesterol and are obese. And so the materials have been useful to her, and really interesting. We're getting a resounding, can I come back for a refresher course from people, which is obviously means that they liked it, that they want to come back for more. I don't know if we answered the questions in the chat. We do really appreciate any kind of evaluation that you can give for this. So somebody, Marta Navarro, is asking if people with diabetes, if MCN can give them the glucometer or the machine to check their sugar. And MCN isn't a provider of direct patient care. MCN works with the whole community of people who take care of patients, and so we don't have access to giving the glucometers. And I am not going to lie, one of the things I hate in my job is I have to prescribe a glucometer because I never can find it in the electronic health record, and the glucometer may be different, a different brand, depending on your insurance. And I have to say that whenever I have a glucometer, the first thing I do is go to Freddy's, who's the community health worker, and I'm like, Freddy's, they have Cigna insurance. What glucometer? What's the name? What are the strips called? Because that's a challenge for me, and so I really rely on the community health worker to help get that glucometer for the patient.
All right, thank you, Lois. And we're almost out of time here. So really quickly, go ahead and do the evaluation. We will get certificates of successful completion for your participation if you fill out the evaluation. I'm going to be sending everyone a follow-up email with links to the recordings, both English and Spanish, including the evaluation links, both English and Spanish. And then you will all get a PDF of this presentation. And I will also include a couple of other links to resources as well. So with that, thank you very much to you, Lois. Danae, thank you to you as well. It was a pleasure having you in the class this year, and I hope you apply in coming years. And with that, I think that will be it for our presentation for today. If you have any questions, feel free to email me. And again, you'll be looking in your inbox for that follow-up email. And thank you to our interpreters. All right, everyone. Thanks again. Have a great rest of your day. Bye-bye, everybody.